is about speaking that 67 years female uh, presents to the GP with 10 days history of vomitings. The person is having vomitings. So this person is coming to the GP with vomiting and contents is gastric content, specifically gastric content. Anytime and no associated factor, GP surgery, she collapsed but does not lose consciousness. So she has fallen and she is sent to emergency department. Pulse heart rate is 105, BP 105 by 55, and there is epigastric fullness. Now this patient has vomiting. So what can be the questions? One possibility. So this is just a case of gastric outlet obstruction. So basically, what is the pathology? This is esophagus, this is fundus, and pylorus, then duodenum. So the gastric outlet obstruction, it has to be at this site. So this is the site where there is GOO. So keeping this pathology in the mind, whatever vomitings is coming out, it is with the gastric content. So how can be what is the vomiting when the person is having obstruction at this level. So this is acidic content. So when acidic content is lost, the patient develops alkaline. So acids are lost. So acids are hydrochloric acid. So hydrogen ion is lost, chloride is lost. So what happens in this? Patient goes in alkalosis. One thing. Hydrogen ion is lost out, chloride ions are lost out, and there is again bicarbonates. So what happens is that hypokalemia. So this especially there is hypokalemia, hypochloremia, metabolic alkalosis. So potassium is also lost, chloride loss, and acid lost. This is the typical picture of gastric outlet obstruction. So there can be increased creatinine, but hypokalemia decrease the renal perfusion. Why hypokalemia? Why the potassium is significant here? So it is lost in the exchange of potassium and sodium. So sodium is preserved, potassium is lost. So what will do in addition to fluid? Now patient is already lost the vomiting. So there is what bedside procedure can help to solve this, because there's a lot of stomach dilatation is there. So you have to put nasogastric tube and put the catheter to resuscitate the patient, because there is sometimes acute dilatation of the stomach. The stomach is dilated. So addition to, as a surgical assistant, who will be involved? So many doctors here, surgical consultant, one is consultant, then HDU, high dependency unit level, and nursing staff anesthetists. Now what patient becomes fit for surgery, any surgery, so when he will become fit? So electrolyte imbalance is to be corrected first, and metabolic disturbances. So what is IV fluids? Which IV fluids you are going to use to correct it? So need sodium, replace sodium, chloride, and potassium. These are the three things which has to be replaced. Correct metabolic component. So for this, Hartmann's is the best solution which contains all the three. And hyponatremia, when sodium is less, how will be the picture? The patient has cerebral edema, so confusion, there can be seizures or cardiac arrhythmia. So these are the things which can be presented. Now what happens? This leads to aciduria. Aciduria. So dehydration lead to increased aldosterone. What is there when the patient is vomiting continuously? So that causes dehydration. Dehydration leads to secretion of ADH, antidiuretic hormone, and aldosterone. So aldosterone, what does it causes? Aldosterone acts on distal convoluted tubule and collecting duct. Sodium is absorbed back and potassium is secreted out. Sodium in and potassium out. So along with the potassium, hydrogen ions also goes out. So there is aciduria. Hyponatremia, it can be decreased sodium. This can be of three types: iso, hypotonic, and hypertonic. So hypotonic means the volume, hypovolemic hyponatremia. So whenever there is diarrhea, vomitings, or diuretics, so all the electrolytes are lost, and that is hypotonic. And volume is also goes down, so hypovolumic. Again hypovolumic hyponatremia. And euvolemic means volume is normal but electrolytes are lost in syndrome of inappropriate antidiuretic hormone or hypothyroidism. Now hypervolemic, so hypo, iso, and hypervolumic, this is about volume. So hypervolumic when there is heart failure, pseudohyponatremia, and multiple myeloma. So what can be the complications? Decreased sodium. What can be the complication when sodium is decreased? So it can be on heart. The most important is heart. It can be on brain. It can be on respiratory respiratory system. It can be on liver, and what it will do on kidneys. So let's see for heart what it has. There can be myocardial infarction or heart failure. And what about respiratory? There can be shortness of breath. Patient has got and chest pain. And what happens for this shortness of breath and this chest pain will be for the respiratory. It will be shortness of breath and chest pain. And what will happen with the brain? Edema is there. So there is convulsions, confusion, seizures, level of consciousness. And liver, what will happen with the liver? Hepatic encephalopathy. And kidneys, what will happen? There is again renal failure. So all these organs. So now coming to the important point, what is causes of gastric outlet obstruction? What can be this? There are the two things, benign and malignant. Malignant we all know. Let's talk about benign. What can be the benign? So how is the benign? Benign is generally stenosis, pyloric stenosis, secondary to peptic ulcer and all that. And this is gastric or pancreatic malignancies. Now sodium bicarbonate. So is it in the whole? As a whole, it is soda bicarb as a whole. What is chloride shift? You already read this. This is cell. The shift of chloride ion to intracellular component of RBC. This is RBC. Chloride is going inside. So in exchange of HCO3, bicarbonate goes out. What bedside test you will do is ABG, arterial blood gas analysis. One clinical picture, how it will be Dehydration, non-bilious vomitings. Vomitings will be non-bilious, gastric content. Fullness, abdomen fullness, peristalsis, visible peristalsis. Elderly man, epigastric pain, sudden, sudden pain, and he's confused. Confused. So ECG and chest X-ray is already given. So you have to look for chest X-ray and define the findings. So first of all, name, age, hospital number, and date of X-ray. So X-ray date. So you have to see it and read the ECG. What you have to read again, patient's name, and then all the things. Then rate, rhythm, intervals, PR interval, QRS, QT, and axis. These are the things you have to understand. So how will be the X-ray abdomen? It's X-ray abdomen standing. See for the things what you have to see. Again, X-ray has to be read in this manner: A, B, C, D. So A is the airway, whether trachea is central or deviation, rotation, pneumothorax, effusion, whatever is there. Breathing, you have to see for lung fields. Lung fields. So you have to understand about lung field. There is a fluid, there is consolidation or collapse, or there is hilar lesion, lymphadenopathy. Circulation, you have to understand about the heart shadow. It should be around 50% of thorax, complete thorax, central. So AP diameter and pH position, whether it is displays, shape, borders. So right border, left border, and ventricles. So vessels, aortic knuckle, mediastinal width. So what about diaphragm? These diaphragm. Then again, see the shape, whether normally right side is slightly upper, left side is lower. So look for costophrenic angles. These are uh, costophrenic. Uh, blunting indicates effusion. Then air under the diaphragm is the right side. If you see air under diaphragm, then indicative of viscous perforation. So that is important. Then if you find air under diaphragm, what can be the differential diagnosis? What are the different DDs? So you suspect perforation, peptic ulcer, then you see perforation of all the things, diverticulum, or it can be appendix, or anything, any bowel, small bowel and all that. It can be necrotizing enterocolitis. It can be ischemia of bowel and malignant pneumoperitoneum. So how will you manage such patient? So you get a perforation peritonitis. It has to be managed by CRISP protocol. So here A, B, C, D again. Airway, breathing, respiration. You have to start oxygen. For that, high flow oxygen, keep the patient nil by mouth. Resuscitation from the fluids, and after management, patient needs exploratory laparotomy. This patient needs surgery. You should consider abdominal pain, maybe myocardial infarction may present. That should keep in mind. Then how to take the consent? If the patient is shocked and confused, patient is shocked, old man, confused, So the consent issue of the consent should not come in. So consent 4, form number 4, two consultants can sign for the benefit of patient. So ECG findings, what you will see, you have to understand about ECG in perforation on old man. It can be because of hypokalemia or something or like this. So you have to understand the regular rhythm or atrial fibrillation or absent P waves when the heart differs in machine. So what is the difference? Heart rate differs in machine as well one as if you do pulse counting and atrial fibrillation, patient is having atrial fibrillation. If you count the pulse, machine has got different and you are getting the different. Why? Because atrial fibrillation causes inadequate heart contraction, resulting in small volume of pulse and automatic machine cannot measure it. So what are the causes of atrial fibrillation in general? So it can be generally hypoxia, electrolyte imbalance, myocardial infarction, hypothermia. So temperature goes down. So that is one of the thing. In this patient, again, because of hypokalemia, sepsis, ischemic heart disease. So now atrial fibrillation has to be managed. It has to rate control, control the rate, control the rhythm, and give anticoagulants. Anticoagulant. So rate control, it has to be given by beta blocker. Rhythm has to be regularized by amiodarone. This around 1200 milligram. First 300 should be initially given 10 to 15 minutes. Anticoagulants like unfraction heparin, 80 units per kg as a bolus, then 18 units per kg per hour. So 8 to 18. APTT has to be measured. It has to be between 40 to 60. So these are the things which needs to be. What are the risk of perforation? So what can be the risk factors? So why there is risk factors? Perforation, it can be because of non-steroidal anti-inflammatory drugs, NSAIDs, most commonly people using H. pylori, infection, or it can be a patient is on steroids. This can be previous peptic ulcer. There can be malignancy. So how NSAIDs? So most of the time NSAIDs, patients are using NSAID and that leads to perforation. How does NSAID leads to perforation? So it is irritant, topical. So topical irritant. So it impairs barrier properties of mucosa. Then it causes decreased prostaglandin synthesis, which is protective by inhibiting cycloogenesis. It decreases mucosal blood flow. So blood flow is decreased. Then interference, superficial repair. So it interferes with the repairing of mucosa. So these are the causes. So the stem of perforation peptic ulcer may continue. It can be either viscous or peptic ulcer. Here it can be a 50 years male, a smoker. The patient is smoker, history of NSAIDs. Patient is taking tablets for osteoarthritis. So acute abdominal pain, epigastric pain, tenderness, rigidity all over, then the bowel sounds are not very clear. So this is, and you get an X-ray, chest X-ray, lung fields, there is gas under diaphragm. So when you see gas under diaphragm, that is peptic ulcer perforation. So what can we confirm the demographic of the patient, free intraperitoneal gas is seen, comment on the trachea and all that. So smoker, NSAID is the cause. Risk factors for perforation, again it is NSAID, steroids, H. pylori malignancy. How can a use of NSAID promote ulcer perforation? Because what happens, the prostaglandins are suppressed, so that is protective to mucosa. So this is one important thing. So the COX-1 or COX-2 inhibitors, so that inhibits prostaglandins. Then it is a topical irritant of the mucoepithelium, impair the properties of mucosa to heal, decrease mucosal blood flow and all these causes. So it has to be managed by CRISP protocol. Definitive management will be laparotomy, doing omental patch or suturing, peritoneal toilet and drains and biopsy to rule out malignancy. Do you know the meaning of? So some of the questions can ask as NCEPOD. NCPOD. So national confidential. So this national confidential inquiry post-operative outcome of death. This is death. National confidential inquiry post patient outcome death or patient outcome death. So classification of the operation, whether it is urgent or it is routine. So what medications would have given the patient post-operatively? So patient should need post protein pump inhibitors. How PPI works? So there is hydrogen potassium pump. So this pump causes secretion of hydrochloric acid, lot of hydrochloric acid. So it binds this hydrogen potassium ATPase enzyme on the gastric parietal cells. So these are gastric parietal cells that blocks secretion of hydrogen ions combined chloride to form HCl. Physiological action of HCl, hydrochloric acid, why it is secreted in stomach? So it helps in digestion of conversion of pepsinogen to pepsin and then protein digestion. It stimulates release of cholecystokinin that and secretin. Then this leads to release of further. It is an antimicrobial. So microbes are there. So acids cause antimicrobial and absorption of calcium. Secretion of hydrochloric, it can be three phases. One is cephalic, second is gastric, and third is intestinal. So when the imagination of the food and all that, it starts secretion. So majority is by the gastric phase. So this is about the wants to see 30-year female patient who underwent total thyroidectomy. So the same patient post thyroidectomy for thyroid complaining of numbness and tingling. So here is numbness and tingling. So again now it is about the calcium homeostasis. So how calcium is? So first question is calcium transport. So there are different forms, free ions. So it is 50% bound to plasma protein bound, again around 50%. So active ion is ionized calcium. So ionized calcium is actually active. So corrected calcium, how to measure corrected calcium? It is equal to definition of corrected calcium in relation to the albumin. So calculation is serum calcium plus 0.8 into 4 minus serum albumin. So this gives 4 minus serum albumin into 0.8. So actually there has to be some addition of serum calcium. So corrected, this is protein bound calcium. So you have to add serum calcium, that will be corrected calcium. What are the EC findings? So what will get in calcium when it is increased, when it is decreased? So calcium is stimulant So QT will be short and ST will be short when calcium is increased and there is prolonged. It is a stimulant. So QT is prolonged. There will be J waves. There is torsa dis D point is. Why the patient with hypercalcemia develop abdominal pain? So pains, moans, groans, stones and pains. So abdominal pain. It can be peptic ulcer, pancreatitis, or stones. It can be any of the three. How renal failure could cause hyperparathyroidism. So renal, what is there? Renal failure is there. Kidneys are failing. So that leads to loss of calcium. Lot of calcium is lost. So that calcium is lost. That stimulates parathyroid gland to release parathormone. So that leads to hyperparathyroidism. How do you how would hypocalcemia be managed? Now calcium is less, so management, how it has to be managed. So important thing is you have to do the ECG and you find immediately IV 10%, 10 ml for 10 minutes. So that is calcium gluconate. Gluconate infusion has to be given to check the paresthesia, muscle spasms, and check whether arrhythmia is there, measuring calcium plus ECG, T wave. So you get T wave inversion and prolonged QT. QT is prolonged. This you have to immediately measure. Most likely cause of hypocalcemia in surgery. There is accidental arterial injury or devascularization. Outline how vitamin D is produced and metabolized. So vitamin D, how it is produced. First of all, skin. So exposure to sun rays. So initially what happens, cholesterol is, dehydrocholesterol is a precursor converted to vitamin D3, cholecalciferol. So dehydrocholesterol converted to cholecalciferol, D3, vitamin D3. And this is converted in a liver to 25 hydroxy cholecalciferol or calcidol. Then this goes into the kidney to convert it into 125 hydroxy cholecalciferol, that is vitamin D or active vitamin D, alpha hydroxylase, that is calciterol. This is called as calciterol. What is the role of free and ionized calcium? Calcium, what does it causes? It has got action on nerves, muscles, maybe skeletal, cardiac, blood coagulation cofactors, in hormone release, insulin secretion, insulin, parathormone and all that. What are three mechanisms? Parathormone through its, what are the three mechanisms? Parathormone, it increases level of calcium. So PTH, it causes increase serum calcium. How? Increases absorption, so it acts through, first of all, bone, kidneys. So bone resorption, bone is resorption and calcium is released into the blood. And kidneys, it acts on calcium absorption in distal convoluted tubule. So activation of vitamin D by activation of vitamin leads to calcium resorption. D. She uses wheelchairs. Constipation. Patient is having long-standing constipation. Now presented with abdominal pain, abdominal distension, old age, constipation, distension, vomitings, dehydration. Think of volvulus. And now you get an X-ray, and here again lab investigation shows sodium is low, ABG gives pH 7.5, PCO2 4.2. This is not issue. Now picture I have past medical history and X-ray showing coffee bean, large dilated coffee bean appearance on X-ray. So this is sigmoid volvulus. So what happens in this? Metabolic alkalosis. Potassium is lost, acid is lost, dehydration, vomiting, always there is alkalosis. So lot of hydrogen ions are lost in vomiters, and renal tubules cannot be, there is loss of chlorides and retention of bicarbonate. So alkalosis there. Hyponatremia. So why there is sodium low? So what happens? Kidney excretes bicarbonate, soda bicarbonate. So in this blood alkalinity, to reduce the alkalinity, so sodium is also lost in the vomiters. Hypochloremia because of vomiters. Hypokalemia, increase aldosterone. Potassium is lost because a lot of potassium is present in the distal, and due to increased aldosterone, this tries to respond to reabsorb sodium and goes potassium out. So water is also. Then why raised bicarbonate? So whenever there is renal tubules uptake in response to chloride, so there is chloride shift. So bicarbonate is taken, chloride is in. So aciduria, hydrogen is now exchanged with sodium. How do you manage the patient? So this patient has to be managed. Again, this is sigmoid volvulus. Patient is critical, severe abdominal pain. It has to be managed by CCRISP protocol. In this CRISP protocol, you have to keep everything A, B, C, D. Then abdominal, you have to keep patient NBM, put nasogastric tube. Then you have to put a catheter, urine output to manage IV access for resuscitation. Monitor the vital signs, blood pressure, urine output, capillary filling, mental status, early distortion. Definitive management will be sigmoidoscopy. And again, if it is not relieved with this, you need laparotomy. Now, what is the signs and symptoms of sigmoid volvulus? So distension is there, constipation is there, patient has vomitings, it can be feculent vomitings, it can be signs of dehydration, tenderness. So what can be the complication? This may lead to gangrene, and this may lead to septicemia, and then it can lead to perforation and sepsis. You are going to involve colorectal surgeon, anesthetist, intensivist, so ITU and cardiologist. So volvulus is twisting. What is the definition of volvulus? This is twisting of around the axis, bowel mesentery. It can lead to obstruction of the lumen. The rotation can be the lumen 360 or 180 degree. What are the risk factors? Volvulus, whenever there is constipation, old age, this is distended and laxative abuses. What are different surgical options? What can be done? The best thing is Hartmann's. So there is Hartmann's procedure. You have to just distal hand is left inside, proximal hand is brought out, and diversion is done, or manual distortion. What are the, if hyponatremia manifestation can be again low sodium, arrhythmias, confusion, convulsions, fits, and causes of this is hypovolemic, hystonic, and all this. So another stem where you can get the patient is 55-year-old, Now this patient is having passing blood in the stools. So bloody diarrhea. So BP is low, pulse rate is high, temperature is increased. Then resuscitation IV fluid lab results hemoglobin less. What can you see in the blood picture? So what are the findings in lab? You get low hemoglobin, increased WBC count because of infection, low platelet, decreased sodium, potassium because they are lost, increased CRP, urea, creatinine. So what type of anemia? So here again there is microcytic and hypochromic. So this type of deficiency of iron deficiency or something, platelet count, maybe platelet because of dehydration. What comment on this platelet count? Maybe elevated. Platelet is high, WBC high, and platelet is high because this dehydration and hemoconcentration. What are causes of thrombocytosis in this case? So why platelets are increased? So here is it is called as thrombocytosis. So why they are increased? Acute phase or dehydration. In dehydration, there is hemoconcentration. What are acute phase reactants? PRP, ESR, ferritin, procalcitonin. If X-ray is done, what you are going to see? So this patient is having bloody diarrhea, dilatation of acidic concern with narrowing of the descending colon, thumb printing, colitis. In colitis, there is inflammation or there can be thumb printing. Thumb printing. So what is this thumbprint sign? Thumb printing is a sign. So if suppose this is a colon and you get on X-ray, so there is like this. Is the radiation appears X-ray in context of bowel condition. Whenever the bowel mucosal folds, there is inflammation of these folds, and that leads to just appearance like thumbprints. They can become edematous resembling thumbprint protruding into the lumen. So it increases colitis. What are the common causes of bloody diarrhea? So bloody diarrhea, it can be ulcerative colitis, Crohn's disease. These are two common things. Ischemic, or it can be infections. Ischemic colitis, carcinoma colon, angiodysplasia, and all that. So, in the view of blood loss and hypotension, will you give the blood? No, because blood loss is there, but because sepsis not included, HB is less than 7. If acute patient cardiac history, indication transfusion. What has caused mentioned electrolyte disturbance in the patient? Loss of diarrhea. Apart from the lab test and X-ray, what other tests would you like to request? So what other test you are going to do is, apart from this lab test and X-ray, what are the other tests would you like to do? So common ESR, CRP, procalcitonin, inflammatory markers, then stool analysis for any antibiotic culture and sensitivity. So antibodies for ulcerative colitis, you have to look for antibodies. Anti-nuclear ANCA and PNCA, PANCA and ANCA. These are the antibodies. Fecal calprotectin. So this is the one test. Carcinoembryonic antigens for malignancy is tumor marker. Colonoscopy you can do to rule out angiodysplasias or acute attacks once subside. How can you understand the patient is improving? So if the fever settles, improvement you get fever is settled, fever goes down, and diarrhea stops, CRP, WC counts goes down. If the cause of diarrhea is ischemic bowel disease, when would surgical intervention be option? So now surgery is required when there is toxic megacolon, colonic bleeding which is not stopping, if there is perforation, obstruction, either for cancer or benign. So procedure of choice. What is the procedure? What you will do? Acute, either colectomy plus ileostomy, elective panprotectomy and ileostomy. So this is another stem where you get a 60-year male, history of old laparotomy. Already patient has gone history of laparotomy. Central pain, omitting distinction. Patient he has become confused. Radiological findings will give dilated small bowel loops, that is intestinal obstruction. So what you will do, abdominal X-ray, contrast and ultrasound. How will you manage the patient? Again, this is the patient having intestinal obstruction. The CRISP protocol has to be there. Assess circulation, heart rate, blood pressure, capillary filling, urine output, level of consciousness, CVP and all that. Capillary fills has to be more than, if it is more than 4 seconds, it indicates there is hypoxia and dehydration. So how do you know patient is hypoxic? You have to investigate patient is hypoxic means pulse oximeter and ABG will show. What to expect in ABG? So what ABG will give? In these patients, there is metabolic acidosis. And HB, if suppose it is dropped from 13 to 9, so it means there is bleeding inside and there is lot of blood loss or overhydration because of dilution. So what are the factors that affect tissue oxygenation? So you are talking about oxygenation. So it depends upon hemoglobin content, cardiac output, PO2, partial pressure of oxygen, and HB. So these are the things. So oxygen delivery, how oxygen is delivered? Oxygen delivery depends upon, first of all, cardiac output into hemoglobin concentration into oxygen saturation into 1.34. These are the three things: cardiac output, hemoglobin concentration, saturation of the oxygen. How oxygen is carried in the blood? It's through the hemoglobin, carboxy. Factors influencing affinity of hemoglobin to the oxygen. So factors that affect hemoglobin and oxygen. So what are the factors that affects this affinity? So there can be shift to the right, shift to the left. It depends upon, the important thing is pH, temperature, then 2, 3 DPG, then PCO2 and fetal hemoglobin or what. If pH is, if there is acidosis, it will shift to the right. And if it is alkalosis, it will shift to the left. Then temperature increases to the right, temperature decreases, increase, decrease. 2, 3 VG increases to the right, PCO2 increases, it is shift to the left. So cadet right. So what is C? So again cadet means C is CO2, acidosis, T3 DPG, exercise and temperature. Now he has regained the consciousness. Patient has become conscious instead of confusion. What will be the next? So patient assessment, decide the plan, patient stable, management plan. In fluid, now if you go full blood count, what you see, MCV, mean corpuscular hemoglobin concentration, they are low. This is micro, mean corpuscular hemoglobin is micro, concern hypochromic. So this is basically iron deficiency. How to investigate the type of anemia? Patient is having anemia. So which is this type? What you will do? Total iron binding capacity, serum ferritin, occult blood in stool, GI, scopy. So these are the things you will consider. What are modified early warning signs? Early warning signs. National early warning signs. In this, there is some modification. Bedside scoring index that evaluate patient stage on 6 vital parameters. This is basically heart rate, BP, respiratory rate, temperature, urine output, mental status. So this is the charts: heart rate, BP, respiration. So among cardiac, you see 2, respiratory, you see 2. This is kidney, this is body temperature, and this is CNS. So this generally the chart shows national early warning signs. So what are the factors that affect cardiac output? Cardiac output is dependent on heart rate and stroke volume. So when the heart rate increases, cardiac output will increase. When this decrease, now stroke volume increases, will increase the. So stroke volume depends on preload and afterload. If preload increase preload generally increases stroke volume. Increase afterload will so decrease. So contractility. So it end diastolic volume minus end systolic volume will be the stroke volume. That is generally 70 ml. So the another station where there is a 50-year-old man who has 50-year female, persistent discharge from the umbilicus. So what has done? Exploratory aportomy is done, adenomyolysis done, resection anastomosis done. There is persistent discharge from this. So this is intracutaneous fistula. So what things are generally asked? Definition of intracutaneous fistula. This is abdominal communication. This is the abdominal wall, and this is the bowel inside. So any communication from bowel to the wall, so that is intracutaneous fistula. There is lined by granular tissue between skin and GIT. Now the fistulas are classified as fistulas. Now it can be congenital or acquired. So this can be congenital. It can be simple, complex. It can be high, low. So depending on etiology, inflammatory, malignant. So most commonly it is caused by whenever you do resection anastomosis, there is leak, and after a few months or days, that leads to formation of fistula. Predisposing factor. Why does there occurs fistula? It is commonly resection anastomosis, Crohn's disease, cancer, infection, ischemia. So complications is again sepsis, malnutrition, fluids are lost, skin problems, fluid electrolyte. What could bring a patient with SA in first 24 hours? So in early management in surgery has to be done when there is distal obstruction, because this fistula is never going to heal, or there is sepsis. In patient developed nausea, vomiting, pyrexia, abdominal tenderness, rigidity, what is your diagnosis? Peritonitis. How do you manage the patient initially? So now this patient needs fistula by a multi-dimension team approach. So first of all, resuscitate the patient, give ABCD and SNAP, SNAP, sepsis control, nutrition, antibiotics, anatomical assessment, fluid resection, protect skin, and plan the surgery. What would you consider surgical correction within 1 month after trial? Because first you give conservative treatment, then wait for 1 to 1.5 months, then give re anastomosis surgery. Urgent you need to do when there is peritonitis. How do you manage nutrition? In this, nutrition has to be managed by either total parental nutrition, how to use the TPN, or otherwise IV fluids. What are the factors that prevent it does not heal spontaneously? Doesn't heal spontaneously. So, what can be the cause? Distal obstruction, infection, Crohn's disease, malignancy, radiation, or it is high output. What are the radiological modalities that can utilize for? You can do CT scan, oral or IV contrast, or fistulogram. So coming to the next, old lady, post-operative day 4, anterior resection was done, left iliac fossa pain, tenderness, confused, RR is 28, BP is 80/50, pulse 110 per minute, temperature is raised, urine output has gone, 450 ml per 24 hours. So it has gone below 15. So what is the diagnosis? So here this patient is having septic shock. You have to keep in mind this patient is having septic shock. Why? There is hypotension, there is tachypnea, there is confusion, fever. Sepsis, DDs can be, now you have to keep in sepsis, pneumonia, atelectasis, kidney injury, diverticulitis, any of the abdominal symptoms. How will you assess acute deterioration? So what will be this sepsis assessment? How it is done? So news, NEWS, news 2, National Learning 1 Science Course or local guidelines. You have to go for if the score is more than 5. Parameters of news score are heart rate, respiratory rate, BP, temperature, cautious level, SaO2. 0 to 3, it's okay, score is aggregated and the final total score has to be calculated. What do you mean by sepsis 3? Sepsis 3 protocol. Sepsis 3 is defined as life-threatening organ caused by dysregulation host response to infection, updated in 2016, published 3rd International Consensus and septic shock and recommended. So it is sequential organ failure assessment criteria, SOFA. So quick SOFA, Q SOFA, it involves 3 things: BP, respiratory rate, altered mental status. So GCS, generally GCS is less than 15 and respiratory rate is more than 22 and BP is less than 100, systolic blood pressure. So what are the shock and what are the different types of shock? Now shock can be volume, hypovolumic, cardiac origin, obstructive, vasodilation, septic, neurogenic, anaphylaxis. Septic life-threatening organ failure because mean arterial pressure is less than septic shock. Here there is mean arterial pressure about equal or 65, or the patient is having lactate, serum lactate is more than 2. What is sepsis? Sepsis 6. Now, here is take 3, give 3. So, what 3 things you are going to take? 1, 2, 3. One, two, three. Two sets of blood culture, two sets, serum lactate measurement, and urine output measurement. Serum lactate, urine output, blood culture. And what you give? Oxygen, IV fluids, antibiotics. Give antibiotics. So give three, take three. So take blood sample, measure serum lactate, urine output. Blood gas is given that pH is showing 7.1, PCO2 is 3.5, PO2 is 16.9, and HCO3 is 11, SO2 is 99. So this is acidosis, and there is uncompensation. Bicarbonates are not increased, and CO2 is severely gone down. Oxygen is there. So it's going about metabolic, partially compensated. So you can think that oxygen level by respiratory. So this oxygen has gone little bit up, means respiratory effort is there. So this is acidosis partially. This is acidosis. CO2. Bicarbonates are not led. If this is increasing, it means fully compensated. And electrolytes, in that we have to measure about lactate. Imaging will give what imaging? Ultrasound, chest X-ray. Mentioned who has high index suspicion sepsis clinical presentation. So age, immunocompromise, catheters, lines, recent surgery, hemodialysis, diabetes, steroids, alcohol, pregnant patients. What is 1 hour care bundle for surviving sepsis campaign? Surviving sepsis campaign. So 1 hour bundle care. Major lactates. One thing within 1 hour. Second is blood culture for antibiotics. Again, antibiotics has to be given. Fourth, administration of crystalloids, resuscitation, vasopressors. So general management of the sepsis is start immediately clinical decision making, so that sepsis is suspected, deterioration rational learning wells, and treat sepsis. New oxygen dysfunction, new organ dysfunction should be prevented within 1 hour of severity assessment. New score if it is more than 4. Then what are the different treatments? You have to start antibiotics, local policy, target site infection, take blood immediately, intravenous fluids, crystalloids has to be given, more than 500 ml of crystalloids. So then repeat it, urine output has to be measured, give oxygen, then this is the way. So there is 30-year male, road traffic accident, head trauma, no signs of life. CT, brain done, review the parameters. So hemorrhage, if you get extradural hematoma caused by middle meningeal artery. So it can be head trauma, lucid interval meningitis, biconvex. Subdural hematoma, this is caused by bridging veins. Old age bridging vein, it is crescent. And subarachnoid hemorrhage, rupture of aneurysm. Intraventricular hemorrhage, generally in the babies. And then there are different names like diffuse axonal injury, cerebral contusion, basal fracture skull, subgaleal hematoma. So these are the pictures which you need to understand. So, intracerebral hemorrhage can be the most likely cause of sudden death. At what point do you assess for brain areflexia? So, this is talking about areflexia. So, what will the point where you will detect? Once all reversible causes of coma or apnea, they are excluded. Can you give some examples of reversible causes? So, what are the examples like? This can be toxicity. So, toxicity, it can be antidepressants, benzodiazepines, morphine, alcohol. So, this is toxicity. Then, temperature, it can be hypothermia, circulatory shock, metabolic, like glucose level, additions, thyroid storms, electrolytes, sodium, potassium, phosphate, magnesium. Once you are clear of all these causes, so these are the reversible causes. Now, who is going to examine the patient for brain stem death, and who is going to declare? Two doctors, two occasions different. At least one should have GMC full registration more than 5 years, and no one should be a part of organ recipient scheme. So, what are the clinical features for brain stem death? What points are to be considered? First of all, pupils, they are fixed, unresponsive to light, then corneal reflex. So that says about pons 5 and 7 cranial nerves. Oculovestibular, no eye movement following slow injection of the. So it speaks about again pons 8th, 3rd, 4th, 6th nerve. Motor response. Now you check motor response, any of the somatic area like supraorbital pressure, or you give pressure applied to the nail bed, finger bed, or like that. Cuff reflex. So bronchial stimulation, suction catheter, or gag reflex. If these are done, what is apnea test? So apnea test is done. Brainstem reflex is confirmed. To confirm the brainstem, increase FiO2 to 1 unit. Saturation 95%. Then decrease respiratory rate on ventilator. EtCO2 more than 6. Do ABG. PaCO2 has to be 6 and pH 7.4. So now disconnect ventilator. O2 5 liters per minute. Observe for 5 minutes. Then ABG is repeated 0.5 more than 0.5 kPa. Further rise in PCO2 and loss of respiratory drive is concerned. So what you will consider in brain stem death regarding organ donation, potential donors with absolute contradiction should discuss what are the absolute contradiction, HIV and CJD disease. Do you know any other condition in which donation is highly unlikely when there is disseminated malignancy, tuberculosis active more than 90 years and hepatic failure?